So since I don't have bio, I'm going to let you introduce yourself a little bit, if that's all right. We get to jump in here. Is that a handheld mic okay?
That's fine.
All right. So we'll get started. We appreciate Inspire Medical being a sponsor for us every year, and we know that we hear lots of we hear a lot more about the Inspire surgery and patients who undergo Inspire surgery after they have tried CPAP. And I'm excited today to have Seth join us and tell us about the hypoglossal nerve stimulation and what your role as a sleep tech is in the sleep lab. So everyone, please welcome Seth.
Thank you. So yeah, notice my name does not say RPSGT after it anymore. So yeah, I love my registry labs because I do a desk job now. But they brought me out of retirement for you guys. Who here has not heard of Inspire? I think that's the first time I've ever had no hands go up. That's awesome. All right, let's get into this. All right, yeah, I work for Inspire. Conflict of interest. Okay. Right now, there's really just 3 companies doing hypoglossal nerve stimulation. It's not just Inspire. There are other people looking into this, figuring out other ways. How can we manipulate the hypoglossal nerve to the airway? Levanova, Ixo are the other 2 big companies. We are the only ones with FDA approval, though. Can we remove that?
Yeah.
Okay. So the hypoglossal nerve is the 12th cranial nerve coming down out of the brain. It controls the muscles and movements of the tongue. Important thing to remember, this is a motor nerve. It's not a sensing nerve. The patient is not feeling a shock. They may describe it as a shock, but it's just because their tongue is suddenly getting contracted because we're stimulating that motor nerve. So your tongue is a unique muscle in the body. It can do all kinds of cool things. Go up and down and forwards and backwards, sideways. We don't want it to go backwards. That's bad. That will cause more happening. So the ENT comes in, and we have a whole training crew that works with them. They have to figure out what all these branches here of the hypoglossal nerve do. Comes down, and it's not always this pretty. Where this part causes the styloglossus muscle to contract, pull back. No, it might be up here actually. But they have to identify the retractor branches because they want to make sure they do not stimulate those. They want to exclude those from the stimulation cuff that wraps around the nerve. And then they want to include muscles like the genioglossus and the geniohyoid, inferior longitudinal, include those that stiffen and protrude the tongue in the airway. And by the way, has anyone seen an Inspire patient? That's the geniohyoid. You can throw that term out. So patient selection. CPAP, I love CPAP. My dad's on CPAP. Like you all, I know every option out there for my dad. I have not told him to get Inspired. He uses his CPAP. Why would I tell him to get cut open? We have plenty of visits, okay? Because we all know there's a lot of people who won't get CPAP. So eligibility, adults 18 years and older. We did recently get pediatric diagnosis approval by the FDA. I'll talk about that. Moderate to severe OSA, HI of 15 to 100. We're actually not approved for moderate, mild. No more than 25% of central and/or mixed apnea. This can be tricky depending on how you score, how your doctor looks at things. Inspire will open up that airway. They have to do their own breathing. They have some kind of comorbidity going on. They've got some congestive heart failure. That's going to throw a wrench in things. Pick the right patients. CPAP failure or inability to tolerate CPAP. That's up to the doctor. I've talked to some of y'all here. Sometimes that's just as much as the patient say, there's no way in hell I'm putting this thing on my face. And other times they've been struggling for years trying to be compliant. And then appropriate airway anatomy. One of the other screening things we do is what's called a DISE, D-I-S-E, drug-induced sleep endoscopy. The ENT will sedate them. They'll look at their pattern of airway collapse. Most people have a front to back collapse. That's fine. That's what Inspire looks great on. Some patients have a lateral wall collapse. Inspire actually works on those patients as well. But about 10% of patients will have what's called multiple airways come together. That's a tough airway to open up. And that's a contraindication for Inspire. That's the little lady you think will be so easy, and they take some crazy effort. Okay, so hypoglossal nerve stimulation, a treatment for obstructive sleep apnea patients who are unable to use CPAP. This is an outpatient procedure. They go home the same day. It's about an hour long usually. They go in the morning. Hopefully they're out in like 3 or 4 hours. The sleep remote you see there, that is the only thing external. That's the face of Inspire. They turn it on when they go to sleep, they turn it off. And we also have nightly effects monitoring, just like a CPAP. See, when did they turn it on to go to sleep? When did they pause it during the night? When did they turn it off? Let's see if we can get these videos to work. So on the left side, you're going to see an airway at the tongue base and the soft palate. I messed it up. Is it? But yeah, but it went out of full screen here. Sorry. Help me. See, I'm not registered anymore. I don't know. All right. I'm gonna try to use this. Is this the video?
Yeah. Let's see. Oh, are you trying to play a video?
Yeah, it's a video.
There's no video link.
Okay.
Yep.
I don't know whether video's going. Okay. Anyways, if it was working, it would show you what an airway collapse looks like with no stimulation. If Inspire on, you can kind of see it. It's frozen there actually when the airway's open. And what you see is more of a popping effect. That airway sort of instantly opens up when Inspire turns on. Inspire is not on for 8 hours while we're sleeping. It's on for about 70% of each respiration. It gives that nerve a break. It opens up the airway, lets them breathe, turns off, lets them finish the respiration, turns back on again before that airway comes. It works not just in one spot. Remember, apnea can occur at multiple places in the airway. So we happen to have the tongue base and soft palate effect. All those muscles and things are all tied together. When you push that tongue forward, it pulls everything forward. So on the furthest most spot on the left here, you'll see no stimulation at the palate tongue base, pretty much obstructed. First sensation, Inspire is on there, but only at a level where the patient can actually feel it. They're feeling some muscle movement. That tongue base open nicely. The tongue is going past the lower teeth at that point. That's where we try to start them using therapy. After they've had a month of healing after surgery, they come into the doctor's office. The doctor figures out what amplitude, what voltage is going to move that tongue forward to get an opening like that. That's where we start their journey. And then at home, they're going to slowly titrate up about once a week. And when it's therapeutic, you can see it's opening up the tongue base and the palate base. So on a sleep study, it looks like this. Inspire off, Inspire. And of course, to make this really pretty slide, we had them cruising along and then we turned it off. We'll let the apnea come back and turn it on. Get this. The big takeaway I want you to think about is that this is another tool in the toolbox. Years ago, we had CPAP, and that was it. We had so few masks years ago. There are great new tools. We've got Inspire. We've got better pillows, better masks, better mandible advancement devices. Things are getting better. You've got more tools to work with for your patients. So like CPAP is adjustable. It's titratable. There's adherence monitoring, even a cloud-based solution to share data, just like CPAP. So our care pathway. This is what's going to give you a successful night of CPAP. So they get implanted, there's a month of healing, and they have that activation visit where that doctor finds out when their tongue was messed. And they say, okay, now you're going to start using it all night every day. A month from then, just a phone call. Are you feeling better? Are you using it? And now they can monitor them and see, are they really using it? They're not using it? Okay, stop, we're gonna make some changes. They're not using it, but we have to do something to get them using it. We're gonna change what's their student, what's not comfortable, what they like. We're gonna solve. Then we say, month for that, bring me to the office. See them in person, see how they're doing. Make more things. There are literally thousands of combinations we can call. Thousands. And then once they're using it all out, once they're feeling better, then bring them into the lab. If you bring them into the lab and they say, I feel awful, I'd like to see is it working well. It's okay, don't bring them into the lab that day. Bring them in when they're like, great. You feel better? Okay. You're gonna have an easy night. So like those are snores, that's the stimulation artery. You might not see it, but this is what you want to see. You can see when is it turning on and off. Is it in sync with your breathing? And it will change as you insert deep into these. I'm casual. Shout them out. Okay. All right. So yeah, when you see the artifact, it usually shows up most in the chin. This cup is placed right up here. So you're going to pick it up. That energy radiating from the house. So the chin is the most likely place. And usually you'll see it more on the right side, typically and on the right side, so you might only see it to the right. You might also see some artifact like this. This is what we call telemetry artifact. This is when we're communicating with our implant. We have a telemetry that's placed on top of our implant. 2.4 gigahertz artifact. Similar to see if you have a microwave that causes interference in your lab, or remember when you get like cell phone signals, these are going like it's just some interference, just ignore it. It only lasts a few seconds. That's actually a long signal. You usually see it 1 second. So typically, patient controls it with their remote. They can turn it on and off. They can pause it, and they can adjust the stimulation strength within a range set by the doctor. Usually we give them a 1 volt range, 11 cents. So when they turn it on at night, their remote turns green, they hear a 2-tone happy beat, and they get 1 burst of stimulation. So they see it, hear it, and feel it to know that it's on. Roll over, put the remote on your nightstand, go to sleep. Half an hour later, or whatever the start play is set to, similar to the ramp on the CPAP. Therapy kicks on where it's on with every breath, and then it'll last all night. So the patient turns it off, or it turns off on its own. And they can pause it if need be. They wake up and go to the bathroom, and drink the water. It's kind of hard to drink water when something else is controlling. So the only thing you're going to adjust in lab is the stimulation strength. It goes from 0 to 5 volts in 10 volt increments. Just like CPAP. You're just going to change a number. I'm seeing some apneas, I'm going to increase this number. Just this is voltage, not centimeters of water. The other thing you can adjust is the stimulation timing. That is start delay, the pause time, and the therapy duration. There is no right or wrong with that. That's just for patient comfort. They've been using it for 3 months at home, and maybe they didn't tell the doctor that, you know what, it's taking me a little longer to fall asleep. Can we make my start by 45 minutes? Sure. Or, you know, gosh, I fall asleep instantly, and my wife says, I'm snoring right away. It's annoying her. Can you lower it down to 10 minutes? Sure. They sleep longer on the weekends, and it kicks off at, turns off at 6 a.m. because they turn it on at 10 p.m. Can we make it therapy duration longer? Sure. That's easy. Okay. 3 areas that will make you successful are setting patient expectations and your goals. Make sure they're aligned. So, disease burden. We want to reduce that AHI. Symptom relief. When the patient happy, hey, I'm feeling better. I don't care if I have apnea or not, just that I feel better. That's the thing they want. Most of them don't care about the apnea number. They just want to feel better. And the adherence, are they using it all night every night? And notice that's the same thing with CPAP. Are they using their CPAP? You got to document that. Anybody? Okay, yeah. Well, we're going to check that too. Symptom HR reduction. We're going to see all of that. So they're feeling better. They're using it. Come into your sleep lab. We're going to make sure that that third pillar of success, that HR reduction, is going there. So we're going to start just a little below what they came in at. We recommend 2/10 of a volt. It's just to make it nice and easy for them to fall asleep. Just like with CPAP, they come in, they're only 10 centimeters at home. Some places I know will start at 10, some might start at 4, 6, or 8. We recommend starting a little bit lower, just so it's nice and comfortable for them to go to sleep. Because they're in a strange bed, all these wires on, and somebody's watching. Give them 10 minutes or so of some good sleep, not just wait 10 minutes. Wait till they're in a good sleep, turn this wire on, start titrating. Just like CPAP. Are you seeing apneas? Go up. We recommend go up by 0.1 or 0.2 volts if you see at least 3 obstructive apneas or hypopneas, loud snoring, persistent growls. Then wait 10 minutes. The software inside this generator, the algorithm as we call it, is constantly analyzing their breathing, just like an ASP does. It's constantly analyzing their breathing during the night. Give it time as you start to open up that airway, give it time to learn their new breathing pattern and get in better sync. Now, what if they wake up? If somebody wakes up on CPAP, what do? They wake up and they're like, hey, it's too much. What do you do? Yes. Okay, it's the same thing. We can also turn it off. You say turn it off because it's like they would hit the pause button at home, lower it a little bit, let them go back to sleep, zoom titrate it. Just like CPAP. Just like CPAP. You're going to have to document because we don't have anything that ties in directly to any systems yet. It's not like automatically put in there. So you'll have to work with your vendor to figure out a way to document the changes. Some of them have it built in. You just, like in fire titration, say, okay, we're at 0.3 volts now. Now we just went up to 0.4 volts. Sometimes you have to put in a CPAP channel just to say, okay, we're calling it 4 centimeters. And you put a little tech note in 4 centimeters means it's 1.8 volts or something. Just so you can score it and generate a nice report. So what we see is when the doctors follow that rule of getting the patients happy, making sure they're feeling better, making sure they're using it before they send them to you. Don't just expect you guys to work miracles every night. We see about 70% of patients, we say that they're on the green pathway. They've got good adherence, good benefit, good AHI reduction. That still leaves about 30% of patients that didn't hit all those 3 things we're looking for. It could be if you're on inspiring, nothing for the night. So we have things we can do. We can do these advanced tests. And I'm not going to get into it too much. Our sleep team will be with you for any kind of advanced titration. We have a whole protocol of what you go through in terms of testing and comfort settings. But let's say it's just adherence. You've got an AHI of 0 on that patient, but they just only use it 2.5 hours a night. What do you do on CPAP? You work with those. Maybe the doctor's got to find out what else is going on at home. But I'm just trying to point out that when you follow these guidelines of making sure the patient's ready to come into your lab, it will make your night so much easier. Don't just send them into the lab as the last resort. I don't know, this guy's like it. Send him to the lab, see how he does. You're going to be frustrated. You're going to be really frustrated. All right, pediatric patients. We recently got FDA approval for the Down syndrome pediatric patients. I love these. I went to Children's Hospital in Atlanta quite a few times working with these patients during the study. Also to Mass Eye here. It's been approved for ages 13 to 18, severe OSA. Everyone in the study did have their tonsils and adenoids removed. We did not test them, what we did not. With Down syndrome, there's a wide range for the patients in terms of their ability to describe what they're feeling and how they're doing. So it can be tough sometimes, but who here does pediatrics a lot? That you guys are used to. You're used to it, okay? You just gotta, you do the best you can. Work with them, talk to the parents when you do these studies. But this is FDA approved. This is just, and when I talk to the parents and you hear what changes in their kid, it's awesome. When they talk about how the kids are sleeping, they're not having to get up 10 times a night, and how the kids paying attention in school, and they're not getting these reports from the teacher that's bouncing off the walls or something. It is so cool. So we have a slightly different pathway with these pediatric patients. They get implanted monthly healing, and then that activation visit when they first get turned on, they're going to spend the night to sleep out there. And you're going to find some initial settings to use on the patient. The goal isn't to fix them, it's to find something they can get started with using. So they're going to assess tongue motion, make sure the sensors are all working right, find something that's comfortable, and hopefully you're seeing the start of some effectiveness, and then you send them home. And then over the next, again, 90 days, the parents and the doctor will be working with them to slowly increase. And then in 90 days, come back again for another lab study. Make sure it's working, tune it some more if you need to. Again, similar to the adults, but we start that very first night we use therapy in the lab. All right, shout at me. Questions, complaints. Mm-hmm. Mm-hmm. Yes. Mhm. That's where you want to work with your medical provider about getting the patients in the right spot. Just because they say, oh yeah, I'm doing fine. Okay, you're just, oh, no. Is there a way that the doctor looks yes. Yes. No, even if they don't, right, when they come in to visit, even if they like our dual remotes, or remotes, so they can still download it. That's what we're recommending. Have that on this. If they give you a frustration that they're not right. Yeah. Bring these patients in when they're ready, and it's yes, and most of that device is a battery. It lasts about 11 years. It's good. The technology it's very similar to like a modified pacemaker at its heart, so it does need to get replaced. Yes, up to 40 now for BMI. 40 for BMI. BMI. Yeah. Now that will vary the life insurance. Oh yeah, all the insurance is covered. Oh.
Higher.
Daytime 15. Okay, but to get that.
Big, I'm sorry.
Yeah, it varies. That's why it does vary by insurance. Medicare, Medicaid. For a child. Yeah. But yeah, work with the doctor about the ins and outs of it, support around BMI.
Let's give you a home. So
So after you have patients view everything was good, how often should they do that office? Is it yearly or?
Every 6 to 12 months because they have it in place. It needs to be checked on regularly.
What about sleep study?
So you say, once you've got them like fixed where the doctors have the results, we're going to be for HST.
Okay, thank you.
He wants us to order for sleep studies.
The timer karaoke.
Any other questions? All right, that is the world record for 8 hours of, or whatever we had today of continuing education. So you're all welcome. And by the way, we will start at 8:15 in the morning. So we're going to get in and maybe we can get you out early tomorrow and let you get to the beach. So everybody have a great night.
You go in the extra